At Professional Risk Management Services, our medical liability insurance program for psychiatrists and behavioral health group practices, the Psychiatrist Program, is designed to meet your needs throughout the various stages of your career. As a national psychiatry-specific program, a policy with PRMS can cover child and adolescent, forensic, early career, and military psychiatrists, as well as moonlighting residents and fellows, part-time practitioners, and telepsychiatrists. Learn more about how PRMS can protect you.
Hello, everyone. Welcome to the Washington Psychiatric Society podcast. This is an initiative by the Career Leadership Mentorship Committee to introduce established local psychiatrists with the residents here in the area. My name is Ayub. I'm one of the chief residents at St. Elizabeth's Hospital. I am in my final year of residency, about to graduate. Looking forward to joining the workforce with many of you folks. Today we have joining us Dr. Epstein, a very distinguished figure in the field of psychiatry. He currently serves as the professor and chair of the Department of Psychiatry at Georgetown University School of Medicine. He also holds the position of chief of service at the MedStar Georgetown University Hospital. If that wasn't enough, he's also the physician executive director for behavioral health at MedStar Health, which involves overseeing physician recruitment and quality improvement across their 10 hospitals in the DMV area. Dr. Epstein has been recognized with numerous teaching awards and has served as the president of the Academy of Psychosomatic Medicine, now the Academy of Consul Liaison Psychiatry. Please join me in welcoming Dr. Epstein. How are you doing today?
I'm great. Thank you. Thank you for having me.
I think we can jump right into it. I tried to make the blurb short and concise, and as many people have heard, there's a lot of leadership roles you have taken. As someone who is about to enter the workforce, I have been shifting my perspective from, practicing and honing my clinical skills and a bit more into the ideas of leadership and advocacy work. So, reading your resume, seeing everything you've done, it's been really inspiring. Would you mind telling us a little bit more about this journey in leadership and, your own personal experience?
Sure. Yeah, that's a great question. Nobody's born a leader, and some of the skills might be intuitive, but most of them are not. And so one of the things that most of us say is that we learned leadership skills over time, and we learn leadership skills by making mistakes and then deciding not to make them again. And we learned them through various mentors. And when I was a CL fellow, which we'll talk about in a second, and my mentor, who's on this call, Tom Wise, who's known to all of you, was a world leader in CL psychiatry. And so somebody like Tom and others on this call and others that I've had the privilege of being mentored by, you literally model yourself after them and then try to emulate them and develop. That's the first point that I want to make. And the second one is that you evolve into leadership roles. And for me, I started after fellowship as a CL service director, and then I did medical student education, and then became a program director, and then an interim chair, and then a chair, and then just started to do very basic volunteer activities in national organizations. The ACLP, which you just talked about, and the ABPN. And once you do that, you just keep working and working and working. And sometimes you get to be a leader. And then there's other areas that I haven't been a leader. I haven't been an APA president, and I'm not going to be. So there's paths that you take. and there's paths that you don't take. But it's if there's one thing that I advise you and your colleagues is, get great mentors and follow them and listen to them, just like I've been able to.
Yeah, that makes a lot of sense. As I've been looking back on residency, I do find myself very grateful for the people that have believed in me and supported me even before I believed in myself. That my supervisors that have cultivated that potential in me. So I do resonate with that. I do feel it can be really hard to find good mentors. And I can see myself feeling discouraged by pursuing leadership roles because of that. Why do you think it's important for physicians to keep considering leadership, even if?
Sorry, go ahead.
Well, I was going to say, continue to pursue leadership, even if we aren't able to find great mentors.
You've talked to a lot of other people who can link you with great mentors. They're out there, and every so often, and I'm sorry, but maybe you have somebody who wasn't the greatest mentor, but that's okay. There's a lot of great mentors out there, and there are great mentors in whatever area you want. You have to find what you like. I had outstanding research mentors. I did a pretty good amount of research early in my career, but I just wasn't good enough and didn't have the passion to just keep going in research. But I had great mentors. So if I had said I wanted to do more in research, I would have had the mentors, and I would have gone to those people and said, can you help link me with other mentors, whether they're in the DC area or anywhere else? So honestly, if you don't want to be a leader, it's fine. Practicing clinical medicine, doing education is just absolutely awesome. But if you do want to be a leader, don't give up just because one or two mentors are not the best for you.
It sounds, at least a part of what I'm hearing as well, is the process of mentorship is also, in a way, a process of self-discovery. Kind of hearing what you were saying about research, it sounds like you have, and you still hold some of those people in high admiration. It just wasn't for you.
That's right.
What, I guess I feel my mind being pulled in multiple different directions, coming into this, because I see this challenge in front of me and I'm not fully sure how to tackle it, because now, I wasn't even thinking about the idea of, oh, I may be pursuing something that I don't want. In your journey to find great mentors and find what it is you want, what have been some of the challenges you feel like you've experienced, something you can share on to people that are going to be coming into leadership?
Well, some of the challenges are that you don't always get what you want. And even if you push for something that you want, you still don't always get it. So I can tell you that if you want to have a position in either in what I've done, which is clinical leadership or academic leadership, you're going to have a lot of bosses and you're going to have a lot of people, I hope, saying yes to the ideas that you have, but you're going to have a lot of people saying no. And it doesn't work to kick and scream and complain. You've got to understand that complex health systems, like we have people on this call who work for the federal government and MedStar Health and Nova Health System and the DC government. I mean, these are complex systems. And if you want to be a leader, almost all of us, then there are many leaders, like I said on this call, almost all of us have a boss somewhere. And sometimes for the best of reasons, they're going to say no to ideas that you think are great. And it's a significant challenge, but we've all been there. And you got to be able to cope with that. And if if it's too difficult to work in a complex system, that's why some people say, you know what, I'm just going to do a small private practice or work in a small group practice, which is also just fine.
Yeah, I did feel like my mind was going towards there of if I'm struggling to work in a complex health system like that at a high leadership position over there, then why not just go into small private practice? But I feel like complex health care systems, large enough systems, they do play an integral role in our healthcare. And I might be biased because I'm coming from St. Elizabeth's, but um, you know, I do think it can be challenging, and being in leadership of these complex healthcare systems, what are some of the challenges you've faced in specific to complex healthcare systems?
Well, a complex healthcare system has multiple priorities. And we love psychiatry. And I think there's very few people who I've talked to who've said, I really wish I wasn't a psychiatrist. So, um, my colleagues and people who've been practicing as long as I have are thrilled to have that as a career. But if you work in a complex health system and you think that the highest priority for funding and growth and investment is psychiatry, you're gonna be very disappointed. And so we have a health system, so Georgetown and MedStar Health, and we're lucky because psychiatry is very well supported. But is it going to be as well supported as the Transplant Institute? No. But the Transplant Institute has just supported our hiring a psychiatrist because they know that you can't have physical health without mental health. And so I'm thrilled with that. And if I thought that a complex health system was going to prioritize, needed to prioritize psychiatry, or I couldn't work in it, I wouldn't be happy.
Yeah, yeah. You kind of hinted a little bit about like funding and income resource allocation in a way, right? Which I know can be very demanding, and very difficult to navigate, especially if you're working in places that have multiple specialties. How do we maintain, maybe before we talk about maintaining quality, how can we assess quality and follow up with that if we feel like we don't have as many resources compared to other specialties?
Well, how do we assess quality in mental health care and in psychiatric care? Is that
Yeah.
what you mean? I mean, I would say that we have enough resources to assess quality. The bigger problem in assessing quality in psychiatric care is that we don't have as many objective measurements as many other specialties have, and it's frustrating. I wish that we were all practicing 100 years from now, where I do believe that tracking PHQ-9s is great, and we ought to we can do measurement-based care for depression, but it is not the same as hemoglobin A1Cs, and it's not the same as cardiovascular surgery mortality, indices. And so the biggest problem with monitoring and improving quality in psychiatry is it's hard to measure. I mean, how do you know whether someone who's doing combined office visit psychotherapy is doing an optimal job? By self-report tracking, by reducing hospitalization? Sure, we have, reducing hospital readmissions or something. We have ways, but we're not there with objective measures yet.
Out of curiosity, what are some of the measures we are using?
Well, one of the big national measures, national initiatives that a lot of people are familiar with is called National Patient Safety Goal 15, which is doing evidence-based screening for suicide risk, followed by a comprehensive assessment many places have different ways of doing it. At MedStar, we use a Columbia Screener and Columbia Assessment tool, and you track how often it's done. When is it missed? Is someone doing the proper assessment? Are we getting one-to-one observers when someone's high risk? I mean, that's a very important quality metric, and we do that. This was this is something that I believe is very, very important. On the other hand, I wish we had more of them, but that's just an example.
Yeah, I think safety is definitely a big metric within psychiatry, and
Right.
Yeah, the objective measures can be very hard, very difficult.
And there's process measures that you can do. Outcome can be harder, but you can look at some outcome data like improvement in depression and readmission rate. Or like I said, you can also look at other process measures alone, like tracking metabolic syndrome monitoring, doing metabolic syndrome monitoring in people who are on long-term antipsychotics. I go to Kenya every year and work, and a lot of olanzapine is prescribed, and they can't. A lot of the patients can't afford to get lab testing, and it's a real tragedy because you see them coming back to clinic having gained 30 pounds in 9 months. It's very unfortunate, but if we have a way to track metabolic syndrome and to change medications if we can, or use metformin or something, it can really affect outcomes. So we have ways. I just wish that we had more.
Yeah, and I'm hearing this, I'm starting to share that optimism and hope that within 10 years, maybe sooner, maybe we'll have more objective measures.
Yeah.
I think I can use that kind of as a stepping stone to something you hinted at earlier, and you mentioned your Kenya trips too, is your career in academia, right? I mean, the future in a way starts now, is developing and teaching those things starting from now. Would you mind telling us a little bit more about your journey in academia? You started to hint a little bit at it. I just kind of want to hear a bit more of a broad picture.
I did a fellowship with Tom Wise at Inova Fairfax Hospital. Then I joined the faculty at Georgetown in 1990 and was the director of the CL service. And then about 10 years later, started to be the director of the fellowship. And I did research in quality of care by primary care physicians in treatment of depression, and published a little bit and had one large NIH grant and a couple small ones, but not much more after that, like I said. So I was mostly a clinician educator. So we obviously, I mean, you all know from teaching services, we have residents and students rotating, and I did CL psychiatry for a long time, also did outpatient CL psychiatry. And then in 2000, I had the opportunity to be the interim chair of psychiatry. And, speaking of leadership, I mean, I didn't sleep much the first year or two because every problem seemed like it was insurmountable. And why, back to your point earlier, why would anyone want to be a department chair? Because you wake up in the middle of the night thinking, if this happens, the whole world comes to an end. And then it didn't come to an end. And then the problems sort of repeat themselves to the point where you say, well, you know what, we're gonna survive. And so I've been an academic chair since 1990. And then what happened with MedStar Health, it's a long story, but MedStar Health bought Georgetown Hospital and a physician practice in 2000. So if I said I've been the chair since 1990, I misspoke. So I have not been the chair since 1990. I've been the chair since 2000. And then after that, in the coming years, about 10 years later, our whole health system integrated psychiatry. So at that time, the question for me was, do I want to be the head of psychiatry for the health system, or do I want to be the chair of psychiatry and report to someone else who would be the head of psychiatry for the health system? And that's an interesting question. because if you asked me whether I had a burning desire back when I was a fourth year resident, to be a lead of psychiatry for the health system, I probably would have said no. It's too much administrative work. On the other hand, at that point, and this has, you have many years ahead of you where you have decisions like this to make. At that point, I didn't think I wanted to, I didn't want to have a psychiatry boss. I had enough other bosses, like I said earlier. So, that's what I've been doing for the last, 10 or so years. And I'm just lucky because I'm lucky to have great chairs at each of our sites. I can't see everybody who's here, but Mary Lou is here, and she's a chair at Star Montgomery. And we have academic, leaders in research at Georgetown, and vice chair for education. Lots of people helping. So, and then at some point in the next years, I'll retire, because it'll be time. But there's my journey. And I have to tell you that I still do CL rounds 4 weeks a year, and I still supervise residents, and I don't want to give up the academic part, because to do full-time clinical administration, you're losing A, clinical skills, so I still see patients, and B, teaching skills and the pleasure of supervising, fellows and residents and students. And so I'm not going to ever give that up.
Yeah, I'm inclined to agree. Coming out of my chief residency position too, I do feel I need a break from managing some of my co-residents and some of my other. I do feel a doctor trying to manage another doctors that's what can make leadership difficult. I do share a big interest in clinician education. The academy, the Association of Academic Psychiatry is a big one. They had their conference in DC this year, and I do believe that physician excellence begins at residency. Begins in the teaching.
Yeah.
And as you said, you're still involved in those in some of those practices to keep your clinical skills up, to keep your teaching academia skills. What are some of those qualities you were looking for or you see in residents that, kind of give you a hint this is someone progressing towards physician excellence?
Well, clinical skills is almost everything as a resident. I mean, when if I'm having a mentorship meeting with you now, I would say for the next few years, don't worry about leadership at all. Just keep getting better. And I know you're graduating from your residency, but I'm talking about being the best doctor you can be, and you still haven't finished learning. And so the first is clinical skills. The second is knowing what you know and knowing what you don't know. So you just want to keep learning and learning and learning and learning. And then a third is taking initiative, saying, I'm going to step up and be a leader, or I'm going to gather our colleagues together so we can, improve clinical care, or, measure quality in a new way. So, there's conscientiousness and initiative and flexibility and a passion for inquiry. And then there's empathy and kindness, that you just see someone who's with patients who's just kind, and families, and kind and understanding. It's like, that's 90% of it.
Yeah. Do you think these same qualities can translate to a good leader?
Yes. There are a lot of other aspects of being a leader, and it kind of reminds me of the question of how do you become a good teacher of medicine and psychiatry. And the reality of it is that teachers are thrown into that role without sufficient teaching, education in teaching. My daughter's a teacher, an elementary school teacher, and it's very hard for me to believe that we still have so many doctors who are put into teaching roles, whether it's clinical supervision or, on a unit or whatever it is, and just haven't gotten formal training in supervision and how to be a great teacher. So, some of it is all the skills that I just said earlier, but there's other skills in how to teach in a group, how to engage a whole audience, how to be a supervisor for a student or resident who's having challenges, how to not lecture at people and engage a group in rounds. These things are not intuitive. So back to mentoring again, you need really good mentors, and also it's very helpful to have some training programs in education. So no, not everybody who's a great clinician and who's dedicated to patient care just automatically becomes a skilled teacher. You need to work at it, and you need guidance.
Yeah, I do think there's all wide variety of the kind of residents we teach, and trying to learn how to cater, learning to teach in a way, right?
Right.
Is a very important skill.
Right.
I did resonate quite a bit when you said some doctors kind of thrown in the deep end of having to teach. I feel one of my biggest shocks or learning points through residency is, in a way, not only my role as a caretaker for my patients, but also my role as a teacher in terms of psychoeducation and these other aspects for my patients. I'm still struggling with it sometimes.
Right.
What are some of the things you feel have worked when working with people who may not understand or share as much psychiatric knowledge as us?
I'm sorry. In some skills in teaching. Can you clarify families, or you mean talking to families or trainees, or?
I would say families and patients right now is what I'm a bit more curious about.
Yeah, that's a really, really good question. Psychiatrists are often better teachers than a lot of other doctors because we're used to listening. You've got to look at the person and see if they are understanding, and ask them, ask the patients or the family, like, tell me what you understand. How can I help you? And you learn phrases. One of my favorite is that I learned again in a formal teaching program is that a lot of doctor visits end with, "Do you have any questions?" And the trainers of us said, no, don't do it that way. You say, "What questions do you have about what I just told you?" Because everybody has questions. And it opens it up more. It's much, much more likely to get a real answer, as opposed to, "Okay, I'm done. You don't have any questions, do you?" So engaging and listening, and remembering that we know a lot of medicine, and we might use jargon that people don't fully understand. And so just to remember to listen and to ask the person what they understand is a very important skill.
Yeah, I do think a lot of those roles come into play too, especially, being your work in consult liaison. There's the teaching role, there are medical students, residents, fellows, there's the patients, families, and then there's also a lot of coordinating care with other specialties. You mentioned you did you worked in outpatient, right? One of my biggest struggles right now is quick care coordination for some of my outpatient folks. Not even from necessarily a consult liaison perspective, just trying to work with other specialties on an outpatient basis. I don't know if you shared some of that frustration, and if so, what have you found has helped mitigate some of those barriers for our patient care?
Yeah, it can be very challenging. It's helpful to have integrated care in one health system. There are models. We do collaborative care, the formal collaborative care model in 50 plus MedStar primary care clinics, and the coordination of care is built into that model. I mean, so there's ways to improve communication, that are intrinsic to the model. The other thing is sometimes you just have to get on the phone. And I appreciate that things can be messaged in a chart, and I appreciate that texting is good. But one of the things that we say when we have challenges in care, like a resident will say, "Well, I wrote this in my note," is to say, let's go walk down the hall and find the team and talk to them. And that's a skill that you learn in CL psychiatry, that you talk to people and listen to them and do collaborative care. And sometimes it takes extra time. It absolutely does, but it's critical.
Yeah, I'm hearing a lot of these themes of in-person care, which is it's interesting because I feel this has been an ongoing debate now post-pandemic is telehealth kind of here to stay. Um, I do think it's an interesting debate of, still the benefits of just getting up and going talking to your colleagues, or in a way even seeing your patients in person. Um, yeah, I think that makes sense, just going down the hallway to your colleague's office and saying, let's talk about, a few of our shared folks for a few minutes. Well, I have a myriad of more questions I want to ask, but we are coming a little close to our time, and I do want to make sure we have enough time to answer any questions people post in the chat. I have seen a few questions. I'm going to ask them. If people do have any questions about anything we did talk about in the chat, in our conversation today, please feel free to drop them in the chat or unmute yourself to ask. But we do have one question from Daniel Hicks, from Dr. Daniel Hicks, that we want to ask. They say, how should psychiatrists advocate for medical and mental health issues in an environment which seems to be intent on cutting funding for these important areas?
Hi, Dan. Thank you for such an easy question. I don't know, Dan. I don't know. You can share. Vote. Keep pushing. Join the APA. There's a lot of work, and everybody here is an APA member, obviously, but there's a lot of advocacy work that we can support. For example, parity, which is not perfect, and I know, but it's a lot better than it used to be. Getting funding for collaborative care. I remember talking to Carol Alter, who was, many of us know, who was trying to advocate to get the federal government to pay, to have codes for COCM, for collaborative care. And I tell this story many times that I say, Carol, just, no, it's never going to get paid for. We're not going to be able to integrate psychiatric care into medical care. We just have to have our health systems pay for it. And I was completely wrong, and she was completely right. And that was due to advocacy work to say, this is how we say mental health care is important. And sadly, as we all know, I think it is thought to be by legislators much more important than it was 20 years ago and 50 years ago. And it's sad because the reasons for it is that everybody has a family member or a friend or personal experience with mental health problems, substance use problems, you name it. So at least we have some good advocacy now.
Yeah, I agree. I think getting involved with our local medical and psychiatric associations is very important because they're the ones that really can devote that. Most of us were busy in practice and not able to do that as much, but our associations can do that.
Yeah.
And it's very important now. So
yeah. Thank you, Dan.
good to see you.
You too.
Dr. Marilyn Powell asks, of the many leadership roles you've encompassed, what's the job you've liked the most, and why that one in particular?
These are supposed to be my friends who are asking these questions. So I'm just.
Good question, Bill.
Maryland, I like every job equally. I think that's a fascinating question, and I'm going to answer it in a way that is going to surprise you, I think, which is I can't answer it because it depends on the time of life. So I think that being a CL service director and a fellowship director was just absolutely a total pleasure, but I wouldn't want to do it again, because I just don't want to do that anymore. I did it for a while. So I like everything. And I like what I'm doing now. Um, I also liked national leadership, particularly with ACLP. And this is, it's really great to, that was my national leadership role. What I meant is, particularly with an organization like ACLP, it can be extremely fulfilling because the colleagues are great. You get to hear from people all around the country. So I like everything I've done. But thank you for the question. And no follow-up question allowed from Dr. Powell.
I'm wondering, working in these, national leadership roles, and these could be just my own anxieties, but if we scale back to that large, if we go to that large of a scale, do you feel you have to get rid of a bit of the minutia, or does leadership still consider the nuances in clinical care and the challenges physicians face when, advocating for and treating our patients?
I'm sorry, can you clarify? While you're a leader, can you still take care of patients, or do you mean something else?
No, I guess let me try and rephrase. You talked about your work as president of the ACLP, and I do think the ACLP as a national organization, I guess my own worry is, does the focus of leadership become very broad strokes, or do they still consider some of the detailed nuances that go into physician advocacy and our patient care? Or because it's such a large scale organization, they can only cover the broader picture?
No, I mean, that's a good question. I mean, it's, if I'm still alive, you come back and talk to me in 20 years when you're a leader. But, the leader is just one person. So the ACLP, as an example, has a whole leadership team. And then it has multiple committees and task forces and special interest groups, all of which have leaders. And so if you're asking about the details, yes, that can be done at a committee level. And then the council, the executive committee and the president, yes, has to approve some things. But a lot of the details are not done by the leader. So it works, and this is how an organization, how an organization has to work to be effective. Another way to say the converse is that, you were asking about good leadership earlier. I mean, it is not good leadership to be doing a lot of to use your term, minutia. It is not good leadership to do that yourself. Sometimes decisions have to be made pretty quickly, and you can't get involved with. I had a boss who will remain nameless once, who was not a good leader of people, and would spend a lot of time editing junior faculty papers, which was a very nice thing to do. But we wanted to say, hey, could you spend some more time with the department chairs and be a leader instead of doing minutia? So you have to be able to learn how to balance that out.
I think I cognitively understand that. It's still hard for me to, I think, if I'm really thinking about it, to fully comprehend it.
You can't, you're not, it's not possible for you to fully comprehend it. It's not, this is what I was talking about. If we think about sort of development of a career, you can't understand this unless you were the CEO of a company for 20 years before you did your residency. It's not possible without going through, like if you talk about being the president of ACLP, I was just a committee member as a fellow, and then I was a committee member, and then I was a deputy on a committee, and then I was a co-chair of a subcommittee of a committee, all these things over many, many years. And then you learn and learn and learn and learn it. It takes years. So you're fine.
Well, I appreciate that. I will value that reassurance. We do have another question from Dr. Marilu Jimenez. She says that leadership doesn't just happen because of your experience. it does take a certain personality to tolerate that daily pressure. And you were talking just a few minutes ago about finding that balance between, you know, the responsibilities and duties of a leader versus, you know, what we might get bogged into, those minutia details of other things. How do we learn to find that balance, like you said?
Yeah, I mean, you could say, Mary Lou, it's personality, or you could say it's a little bit personality and it's a lot of learning and adapting over time. I mean, there's certain things that may not come naturally. You can't, I'm mostly an introvert, and you can't be a total introvert and be a department chair. You work on these things that, you try to work on your limitations and weaknesses over time. So some of it is personality, but some of it is also, like I said earlier, learning from role models and adapting and being flexible, and frankly, just knowing that sometimes things go great and sometimes they don't, and just pause and, don't send off emails too quickly.
The one thing, though, I remember, Steve, so for the others who are here, um, Steve was a mentor when I was at Georgetown. So this goes, 25 years ago. And so even then, it seems like we knew you were going to be a leader in Georgetown, that you will become, you know, the chair, even if we don't know that that's exactly what you're going to be. Uh, and there's a certain quality in how you teach that I think, um, we perceive as, okay, he knows what he's doing. And I don't know if that's because you're doing CL, which is, um, quite complicated in many ways. But there is, I hear you when you say there's experience, and I have that. I never walk away from an experience. If something is new, I don't know it, but I can learn it, I'll go for it. I might fail. I've failed, but I learned something from that failure. And but there's again that certain, what is that? I'm word searching right now, but a certain, persona, that people tend to, even if you don't insist of being a leader, people tend to follow your path. Does it make sense? So that's a personality that I'm talking about. But then there's also the personality of, um, you have to step up when the need comes. When something happens, you need to step up. And if you don't step up, then you fall, and it's hard to recover from that. And so I don't know if I'm making sense, Steve, but you're my boss now, and and you're teaching me how to be a leader and all that stuff. So I take it seriously. But how do you acquire that? Yeah, you're introverted. Not. I'm not. I'm a pretty loud and verbose, and I'm one of those who will email you right away. Like, please answer the phone. I need to talk to you for a moment, right? Uh, so I don't know. Is that more of, you learn to take a step back? Is that something that you have to learn actively? Do you say, okay, Mary Lou is just, very reactive, right? And then you go, okay, I was reactive before, and I'm not going to make that mistake again. I mean, is that how it works, or it's not? I don't know.
That's what, well, yeah, Mary Lou, you are a pleasure to work with, as I hope you know. I don't know the data, okay? So I'm not going to tell you the percent that's intuitive and the percent that's learning, but I'm going to tell you there's a lot of learning. And you learn by mentors, like I've said a number of times. I can't tell you how many times I am very happy with how I handled complex situations involving a lot of people and feel good about it. I'm really happy with that. I got to tell you, there's just as many mistakes where I will say, I can't believe how I mishandled this situation, 8 years ago. I'm not going to do it again. But the learning from the mentors, I see someone and how they run a meeting or how they manage conflict, which is a classic thing, conflict among faculty or whatever. And I learn from how they do it. And I want to repeat, I want to do it the way they did. And I learn from people who make mistakes. And so there's a lot of learning. Some of it is intuitive. And but just to your point, Mary Lou, a lot of it is not.
Yeah.
Do you have any more questions? Well, actually, that's not the right question to use, right?
There you go. Great learning. That's exactly right. What questions does anybody have?
I'm trying to model, what additional questions do we have? Okay, well, I appreciate everyone making the time on a Wednesday night to join us. And, I hope everyone will join me in showing our gratitude and saying thanks to Dr. Epstein again.
So I'm going to do a bad teaching thing and interrupt you because I don't want people to go. These people on the call have all taught me, and you've been great. Hi, Connie. I can't see everybody, but been great partners and great mentors. And I've learned from all of you, and you did a great job tonight. So thank you so much, everybody.